محاضرة اليوم بعنوان Fetal Malpresentation Part 2. Fetal Malpresentation. The term malpresentation encompasses any fetal presentation other than vertex, including breech, face, brow, shoulder, and compound presentations. Face presentation. Face presentation occurs when the fetal head is hyperextended, such as that the fetal face between the chin and orbit is a presenting part. The incidence is about 1 in 500 deliveries. As we said, occur when fetal head is hyperextended. We know the normal presentation in labor when the head is flexed, while the fetal head was hyperextended, that the face is between the chin and the orbit is a presenting part. This occurred in 1 in 500 deliveries called face presentation. What are the causes of face presentation? The majority of cases, the cause for extension is unknown, although it is frequently attributed to excessive tone of the extensor muscles of the fetal neck. Rarely, extension may be due to fetal anomaly, such as thyroid tumor or anencephaly. Diagnosis. On abdominal examination, the prominence of the head is palpable at a higher side of the fetal spine. On vaginal examination, palpation of the orbital ridges, nose, eyes, malar eminence, mentum, gum, mouth can be distinguished. It may be difficult when the membrane are intact and the presenting part is high or in the presence of edema due to few hours of labor. So as we said, on abdominal examination we will see prominence of the head. The head is palpable at a higher side from the fetal spine. But on the vaginal examination, this is an important landmark: orbital ridges, nose, eyes, malar eminence, mentum, gum, mouth can be distinguished. This is easily when the membrane are ruptured, but it is difficult when the membrane are intact. And also, if many hours occur in labor, there will be edema, so it is difficult to distinguish these landmarks. Mechanism of labor. The presenting diameter is the submentopragmatic, which measures 9.5 cm and is approximately the same in dimension as suboccipitopragmatic in vertex presentation. Despite this, engagement of the fetal head is late. And progress in labor is frequently slow, possibly because the facial bones do not mold. Molding is important in the descent of the fetal head. If progress in labor is excellent and the chin remains mento-anterior, vaginal delivery is possible, and the hand being delivered by flexion. Here, as you see, orbital ridges, nose, eyes, malar eminence, mouth, chin. This is descent, hyperextended head, as you see, and then delivered by flexion. If the chin is posterior, mento-posterior position, delivery is impossible, as extension over the perineum cannot occur. In these circumstances, cesarean section is performed. So we prefer mento-anterior in delivery, and mento-posterior it is contraindicated for vaginal delivery and indicated for cesarean section. Here, as you see, face presentation, mento-posterior. This is the mentum, mento-posterior, so it is impossible for vaginal delivery. Other presentation is raw presentation. This rare presentation is diagnosed when that portion of the fetal head between the orbital ridges and the anterior fontanelle occur in 1 in 2,000 labors. The fetal head thus occupies a position midway between the extension face and full flexion occiput. Etiology and Diagnosis. The causes of persistent brow presentation are the same as those for face presentation. A brow presentation is commonly unstable and often convert to a face or vertex presentation. On vaginal examination, the frontal sutures, large anterior fontanelle, orbital ridges, eyes, and roots of the nose are felt on vaginal examination, but neither the mouth nor the chin is palpable. So by that we can differentiate between face presentation and brow presentation. You know, as we said, in face presentation we can feel the mouth and the chin, while in brow presentation neither mouth nor chin is palpable. This is brow presentation, anterior fontanelle, orbital ridges, and roots of the nose and the eyes only. Mechanism of labor. A brow presentation, the head is half extended and present to the pelvis with the largest mento-posterior diameter or mento-vertical 13 cm. Number 1. The brow presentation may correct to a vertex during labor by flexion of the neck, or undergo further extension and present as face, which can be delivered vaginally if mento-anterior position. So either vertex by flexion or face by extension and mento-anterior. Persistence of a brow presentation with a slow progress of labor at term is not compatible with vaginal delivery and necessitates cesarean section. Shoulder presentation. Shoulder presentation occurs as a result of transverse or oblique lie of the fetus, occurring in 1 in 300 pregnancies at term. Etiology. Causes of transverse lie include abdominal wall relaxation from high parity, preterm fetus, placenta previa, abnormal uterine anatomy, uterine fibroid, hydramnios, contracted pelvis, congenital fetal malformation. Diagnosis. First, by abdominal examination, inspection, abdomen is broad and large. Palpation. Fundal level lower than expected. The fundal height is lower than the expected for gestational age. Fundal grip is empty. Lateral grip, head at one side and the buttock on the other side. pelvic rib empty and high presenting part. Here, as you see, the heliopoid maneuver. Fundal height is lower than the expected for gestational age. Fundal grip empty. Lateral grip, as you see, head from one side, buttock from the other side. Pelvic grip also empty, and there is no presenting part. On vaginal examination, during pregnancy, high presenting part. During labor, before rupture of membrane, bulging membrane. After rupture of membrane, you may feel axilla or can be felt protruding from the vagina. Mechanism of labor. Spontaneous delivery of a fully developed newborn is impossible with a persistent transverse lie. Neglected shoulder presentation, as you see, if not diagnosed early in labor. Hand is prolapsed through the vagina. This is incompatible with vaginal delivery. Management. Active labor in a woman with a transverse lie is usually an indication for cesarean delivery. Before labor or early in labor, with the membranes intact, attempt at external version can be done in the absence of other complication. Thus to say, if the patient presented in active labor and the membrane are intact, we can do their external version to the fetus if there is no any contraindication for this, and change the position of the baby from transverse to cephalic if the membranes are intact. But if the membranes are ruptured or the woman in active labor, we cannot do that, but we take the patient for emergency cesarean delivery. Now we will talk about compound presentation. In a compound presentation, an extremity prolapse alongside the presenting part, and both present simultaneously in the alongside pelvis. Hand or arm prolapsed, the head occur 1 in every 700 deliveries. Here, as you see, this is the arm, the hand, alongside the fetal head. If the patient comes in labor, we observe carefully. If the progress of the head occur and the hand retracted upward spontaneously, this is okay, and we can proceed for vaginal delivery. If this not occur, we can push it gently upward. But if the hand is prolapsed before the head, before here, the hand come here to the vagina, this is impossible for vaginal delivery, and we must proceed for cesarean delivery. Umbilical cord accident or cord prolapse. This is an emergency, obstetrical emergency. A cord presentation is defined as the presence of umbilical cord below the fetal presenting part when the membrane are intact. This is called cord presentation, different from cord prolapse. Cord prolapse is the presence of the cord below the presenting part when the membranes are ruptured. Here, in cord presentation, the membranes are intact, while in cord prolapse, the membranes are ruptured. Incidence 1 in 500 deliveries and occurs when the fetal presenting part does not fit well into the maternal pelvis, giving space for the cord to prolapse when the membrane ruptured. Here, cord presentation, membrane intact, cord presentation. Here, cord prolapse in membrane are ruptured in vertex or in breach when the presenting part is not fit well and not descend well. Also, as you see here, cord prolapse, cord presentation. What are the predisposing factors for cord prolapse? Fetal causes and maternal causes. Fetal causes: abnormal lie or presentation as a transverse lie breech, multiple pregnancy, polyhydramnios, prematurity, high head, usually long umbilical cord. Maternal causes: pelvic tumors such as fibroid in the lower segment, narrow pelvis. Diagnosis: by seeing the cord and the introitus or feeling it during the vaginal examination. However, an abnormal fetal heart rate pattern may suggest it, as compression of the umbilical vein between the presenting part and the pelvis. Reduce or stop the flow of oxygenated blood to the fetus, causing deep variable decelerations. Then bradycardia if the situation is not relieved. Management: total cord compression for longer than 10 minutes will cause cerebral damage, and if continue for around 20 minutes, death. So immediate management aims to minimize the pressure of the fetal presenting part on the cord. While plans are made to deliver the baby, this is achieved by moving the woman onto all fours, knee to chest position. We put the woman from the supine or lateral position, change to knee to chest position with the head down, maternal head down. Applying pressure vaginally to push the presenting part out of the pelvis. Here, this is knee chest position and the head down, knee chest position, head down, presenting and pushing the presenting part so that not to pressure on the umbilical cord. We elevate the mother by 2 pillows by channeling head down position. Here we push the presenting part to elevate the pressure on the umbilical cord. Bladder also inflated by squeezing 500 ml of saline intravenously. So when we fill the bladder, we can push the presenting part to prevent the pressure on the cord, on the prolapse cord. Filling the bladder with 500 ml of saline, there should be minimal handling of the cord, as causes spasm will worsen blood this flow. However, if the cord is beyond the introitus, it should be placed into the vagina. Keep it warmer. Emergency cesarean section is required unless the cervix is fully dilated, and an assisted vaginal delivery can be safely and easily performed. This is top emergency condition, because delay we may lose the fetus. Fetal outcome depend upon this gestation. Other complicating factors such as intrauterine growth restriction and for how long the cord has been compressed. With a term baby and prompt diagnosis in hospital, the prognosis is usually excellent. If the cord prolapse occurs outside the hospital, the fetus is likely to be dead by the time of admission. Thank you for listening.